And we are live. Good morning, everyone, or good afternoon, or good evening, depends on where are you looking us from. My name is Gianluca Torregrossa. I'm a cardiothoracic surgeon from Philadelphia. And a couple of years ago, during COVID time, while my wife, who is an anesthesiologist, was the front line of a COVID unit, I found myself in a deceleration impact from being every day in the operating room as a cardiac surgeon. I was left behind at home, not doing anything, changing diapers of my own daughter. And I got pretty crazy at the point that I decided to set up these live talks with friends, with colleagues, try to share our knowledge, try to talk about a subject in cardiac surgery, try to advance our field in a very relaxed way on a Saturday morning in front of a cup of coffee. With these spirits, we have done a series of these events. Some of them have been under the logo of International Coronary Congress. Some like this one are completely independent and run by myself with a full aim for me to learn something. And atrial fibrillation is a topic that I feel very keen to, I feel very connected with. I think is another incredible opportunities for surgeons to devote his own skill towards a large majority of patients that are currently present in each center of ours and they've been undertreated. And I think that the concept of offering a minimal invasive option or a more broadcast attention, surgical attention to these patients is a great opportunity. I invited a panel of really experts in the field. We have Stefano, Schena, and Mario Gaspari from Wisconsin and Medical College of Wisconsin, the Division of Cardiothoracic Surgery in Milwaukee. Gan Dunnington, we are waiting for him. He's in the West Coast and probably it's very early in the morning. He confirmed, he sent us his own slides, so he should be hopefully connecting very soon, and he's the director of the Cardiothoracic Surgical Center in St. Helena Hospital, California. And Bart Maesen from Maastricht University unfortunately told us that just last night sent us an email. He will not be able to join for personal reason, but we will do our best to engage with you in a conversation. Feel free to tell us where you are looking us from. Use the comment button in whatever social media platform you are using. And let's start to discuss, share your questions. So Mario, Stefano, we are, this is seems kind of odd that there are 3 Italians here. I mean, seems that we did it on purpose, but I hope to tell everyone that this is absolutely awful transparency. I admire both of you because I think that you guys have introduced a really new concept. And Mario, you really like promoted a new technique in the field of surgical treatment for atrial fibrillation. But before going there, before going technical, before exploring what are the options, I would like to ask, and I will start with you, Stefano, a little bit about your lost opportunity or the opportunity to catch in the field of surgical treatment for atrial fibrillation. I think that there is a need for a cardiothoracic surgeon with experience in atrial fibrillation. Tell me, what is the journey of a successful surgeon that wants to become an expert in atrial fibrillation? How do you get there?
Thank you, Gianluca. Thanks for the opportunity to talk about this very current topic and for inviting me with a panel of expert surgeons in the field. Atrial fibrillation, as I will show you in a couple of very informal slides later, has become an epidemic. Atrial fibrillation is everywhere. And the reason for that is that has always been everywhere. We just have become better in finding it. We test our patients more accurately. We manage them better, and the opportunity here is huge for the reason that multiple studies have already showed that medical therapy or even just catheter ablation or cardioversion are not enough to treat this patient. Certainly, there's a lot that goes into prevention. There's a lot of risk factors that could be managed preemptively, especially in the Western world. But in terms of treatment, the best successful way to manage this patient is with procedures that address both the inside and outside of the heart. I'm just using simple terms because I know that a lot of people will connect and not strictly involved in the field. As far as developing a career out of it, I will show you some key points. I think it's very important, first of all, to learn the lingo that we share with our colleague cardiologists. If we speak the same language, it's easier to understand each other. First, in how we define atrial fibrillation, second, in how we quantify, but most important, what anatomic structure we're going to treat. Surgical treatment of atrial fibrillation in comparison to coronary artery surgery, valvular surgery, or other procedures is way less technical, believe it or not. It doesn't require a lot of advanced skills. However, it does require more anatomical knowledge and anatomical and knowledge of the disease. But most of all, it requires a lot of patience. This kind of require following your patient almost in their lifetime, and a lot of us consider themselves too busy to do that, and this is a mentality we should overcome. But I have, as far as my personal experience, I have to admit I've been trained in an institution where atrial fibrillation treatment, surgical treatment, atrial fibrillation was the mecca. I owe who I am today to the people who trained me. And also you have to be lucky to partner up with colleagues that have the same passion. And I'm lucky to have Mario in my institution, and in previous institution I had other colleagues that had the same interest. You need to partner up with your cardiologist, and I'll show you later the importance of creating a multidisciplinary team. This is as important as structural heart multidisciplinary teams. The heart approach is key.
Yeah, I completely agree, and there is a story that I always tell when that I'm deep passionate about robotic coronaries, and a lot of colleagues come to me and told me, well, but I don't see single vessel disease. The patients that get to me are only in need of 5 bypasses. I cannot do robotic. And I tell them, like, look, reality is that there are single vessel disease, but they get treated by multivessel PCI or PCI only. You don't see these patients because you do not offer a minimal invasive bypass surgery in your own institution, and the cardiologist is less keen to send you this patient. And I believe that is exactly the same in the history of atrial fibrillation. There are tons of patients in my own institution that would benefit from an advanced surgical treatment, but they don't come to me because the EP do not know that I'm a professional. I can offer this type of lesions, this type of setup, this type of techniques. Mario, tell us a little bit your opinion about growing a profession into atrial fibrillation. Imagine you are a young cardiothoracic surgeon. You are 2 years out, 3 years out. You are doing all of the CABG that nobody wants to do in your own practice. You are picking up some endocarditis over the weekend. How do you get from there to become someone recognized in your own center in the atrial fibrillation?
Yeah, that's super interesting because my journey is very different than probably yours and Stefano. I'm a general thoracic surgeon. And when I finished my training, knowing I was going to go into general thoracic, the first thing I did when I finished fellowship was try to forget as much as I could about AFib as possible, because it was always a very confusing entity. It was not my thing. I was a thoracic guy. And then when my cardiac colleagues, and I'll talk a little bit about this during the slide, but when they wanted to start a convergent, a hybrid ablative pathway, but they also wanted to clip the appendage, but didn't necessarily have those skills. That wasn't in their skill set to do VATS or robotics or whatever. So they enlisted my aid, and I said, fine, I can help you with the technical stuff, but I have no I have no knowledge of AFib. But as I started kind of doing more of these with them, I realized it really, it comports well with my kind of thoracic thought process. It's all, the opportunity is multidisciplinary. So like in the thoracic world, we work with pulmonologists, hemonc, radonc. It's this collaborative effort to get a patient through their disease process. And I think AFib affords that exact same kind of mindset where we work with EP, we work with cardiology, we work with all these other specialties, even myself and Stefano, a thoracic and a cardiac guy. But just having that dialogue and having that interaction with your peers is really the first step towards building a program. None of these things are siloed or can't be done in isolation. So if someone's embarking on this, the first step I would tell them is just engage your colleagues, have conversations like we're doing today. Here's what I have to offer. What do you need from me? And here's what I can offer you, and vice versa. Because I think there's always this mentality that one specialty is trying to steal another specialty's patients and excluding them. But this is really, in fact, AFib of a lot of, compared to a lot of other disease processes, this is one where everybody needs each other and we're complementary. So that's what would be my first piece of advice to anyone trying to embark is be engaging, be collaborative, and just be honest. Here's what we have to offer. Here's the shortcomings of that. Here's the positives of that. And let's create a program.
I love it. So go to your EP, get to know their name, get to know the lingo, as Stefano said. But Stefano, tell us, and I put up your presentation, what we can offer to them. Let's go into the little bit of a deep dive. What really a surgeon can offer in the game of treatment of atrial fibrillation. Tell us a little bit more. I will control your slides. I know that you are streaming from a phone. So, like, what is the landscape? How does things look?
Okay, excellent question. I want to focus particularly on this slide that is very representative of what we are up against today. Okay, atrial fibrillation, as I mentioned before, is the next epidemic. The projected number of people who are going to be diagnosed with atrial fibrillation in the next 5 years is going up to the order of several millions in the United States, but even worldwide, and they will continue to grow. And the reason for that, as you can see on the left side of this slide, is the multiple social factors and health lifestyle factors that we are affected with. All these factors are potentially correctable, they are preventable or treatable, and we could potentially act on this upon just to prevent atrial fibrillation. But in reality, we will find ourselves as physicians and as surgeons to treat these patients before anything might change in the next decade and so forth. So if we move forward, I want to make sure that one important concept goes through. In order to get established in the treatment of atrial fibrillation, we all have to speak the same language, as I mentioned before, with your colleagues, with your referrals, with your patients and their families. I still go to meetings or I talk to colleagues, and frequently I hear about, oh, this patient has chronic atrial fibrillation or has acute atrial fibrillation. There is really no such a thing when you discuss atrial fibrillation. That atrial fibrillation has been coded very specifically by all of our cardiology and surgical society, and has been defined in 3 different types based on the duration or self-resolution or resolution based on treatment. Why is it important to know these terms, paroxysmal, persistent, and long-standing? Because the effectiveness of treatment is very different between paroxysmal and the rest of the other forms. And this is important because when you interact with your colleague cardiologists, EP, electrophysiology cardiologists, they will refer to you as a surgeon the persistent and the long-standing. They are perfectly capable of managing the paroxysmal, especially with the current technology that is available to them and that we sometimes use in collaboration with them when we approach a patient from a hybrid standpoint. However, it's important to understand that there is a gold standard that works well, has been proved to work well for decades. And this is what is generally recognized as the Maze procedure. The Maze procedure in the latest iteration, or Cox Maze 4, is the surgical procedure that ablates atrial fibrillation in both atria, and there's the most proved long-term successful results. Okay, this is not the scope of this talk today. I'm not here to talk about Maze procedure. However, the Maze procedure, when provided to the patient, whether as a lone procedure or in concomitance with mitral valve surgery, aortic valve surgery, coronary aortic surgery, it's a procedure that is going to give you the best results in the long term as far as management of atrial fibrillation. But why am I putting this slide about the Cox Maze? The reason is there are barriers in doing things that are due to the fact that those are the standards that have been brought up for many years. Oh, if we don't do a Maze procedure to this patient, we're really not doing anything about atrial fibrillation. Well, this is not exactly true. And as I mentioned before, we do need to provide to our patients something that is durable in time and it is able to cover any type of anatomic reasons. In the next slides, I wanted to show you the fact that the standard that we should try to reach is the standard that is provided by the Maze. The Maze in time has proved results with successful treatment that are well above 80% of resolution of atrial fibrillation. If you show the next slide, one concern that was brought in the past was, well, can we manage patients who have had atrial fibrillation for a very long time and their atria have become so large? It seems almost impossible. In reality, the Maze procedure showed that this is possible and even effectively. And so we need to get to that level, and we need to do it, if possible, in a more practical way and less invasive, if possible. Having said that, we need to raise awareness. The next slide will show you what we have been discussed even at the most recent meeting at the Society of Thoracic Surgeons, but it's discussed everywhere. And we need to establish guidelines so that we have parameters for indication. The next slides shows exactly what I mean. Because the awareness of treating atrial fibrillation has increased, guidelines have been provided, and treating atrial fibrillation either concomitantly or in an isolated form for just the pure arrhythmia, or even just isolating the left atrial appendage, has become a level 1A recommendation. If you go, this is the slides that I meant. Our main society, STS, but even the Cardiology Society in Europe or in the United States have reached this agreement. Treating atrial fibrillation should be a priority. It was not until a few years ago. And as a matter of fact, the level of adherence to treatment of atrial fibrillation is not where we should be. As of last year, there have been studies showing that less than 1/4 of the patients who are treated surgically for other pathologies and also have concomitant atrial fibrillation received surgical treatment for that. We can do better. We can do better than that. However, there are perceived barriers that come with it. If you go to the next slide, I wanted to show what these misperceptions are in terms of barriers. First of all, everybody thinks that these procedures are necessarily invasive. Well, Maze procedures, whether for 180 or 2, although even here we have to be very precise, a Maze procedure is a biatrial ablation, can be done in a minimal invasive fashion. However, there is still a lot of misinformation about what are the anatomical targets and the lesion set we have to provide. And why is that? We've been giving misnomers to these procedures. Everything is called Maze procedure, but in reality, a Maze procedure is only the biatrial ablation. And then we've tried to minimize to the lesion sets everywhere, and therefore creating confusion even when we communicate with our colleague cardiologists. I have to admit, until recently, there has been a lack of exposure during surgical training. That's because a lot of practitioners, both in academic or in private practice, don't perform this procedure. Therefore, trainees that are in those programs are not exposed frequently. They have to go to additional training. They have to go to special programs that are provided by societies, or they have to go visit other institutions. I mentioned the mislabeling of the performed procedure, but there is also still, even among surgeons, a lot of distrust in the efficacy of ablation procedure. A lot of surgeons don't believe that patients actually do better in the long term. We need to change that mentality. The same cohort of surgeons think that adding an ablation procedure to a coronary artery bypass or a mitral repair extend significantly the duration of cardiopulmonary bypass and cross-clamp timing, and they don't wanna get into that, rightfully so, fearing that this might increase the rate of complication. One important aspect is the lack of immediate gratification with this procedure. Why am I saying that? The reason is we frequently ablate patients, whether through a standard Cox Maze 4 or in minimal invasive fashion, and these patients flip back into atrial fibrillation within 24 hours or even right before discharge. And we get frustrated. We think we have not provided the right treatment, but this is not the reality. There are factors that affect the recurrence in the acute phase of the postoperative treatment that are unrelated to what you have done, and that will resolve in the vast majority of cases. You need to be patient with your patient, and you need to be patient with the condition you're treating. If you trust your lesion set, the atrial fibrillation will be successfully treated. And therefore, that misperception of long-term benefits is not justified. Also, as I mentioned before, have better communication with your cardiologist. They will refer patients to you if you speak the same language. And last but not least, this is a concept we have debated during the last Society of Thoracic Surgeons meeting. Share the burden of the follow-up of this patient. Follow up on them. The only way to know if you have successfully treated them is to look at them in the long term. If you just bounce them back to your referral, you're never gonna know what happened to them, okay? So why we need to move past the concept that the Cox Maze procedure is the only way of treating them? Because there are initial randomized studies that have proved that we can achieve results that are somewhat close to what you can achieve with a Maze procedure, even with an hybrid approach that does not necessarily entertain the use of cardiopulmonary bypass or cross-clamping. Here I'm citing the main 3 randomized controlled trials that have showed that hybrid approach is better than just catheter ablation or medical treatment. However, as you can see, all these randomized trials include a very small number of patients. We can do better. We can enroll more of them. We can do better study and prove that this hybrid procedure actually works. And look at the next slide. You might notice how our colleague cardiologists tend to entertain already the idea that hybrid ablation is a reasonable treatment for long-standing and persistent atrial fibrillation. However, their priority is still catheter ablation. They are recognized, though, in their guidelines that if we approach this patient from an hybrid standpoint, we can do better. So, if we go to the next slide, these are my last 2, and then I want to go into practical things. If you notice, the efficacy of the Cox Maze procedure in time is shown to be in the best studies, to be years after years, around 60, 70, 80%. You have excellent results in the first few years, up to 5, in the order of 90, 80%. But inevitably, some patients have recurrence, they develop new pathways of atrial fibrillation. Can we achieve the same results with hybrid approaches, minimal invasive approaches? Yes, we can. And so the next slide show what I think should be the take-home message from today's webinar. We need to provide minimal invasive approaches that are more palatable, appreciated by patients and referring physicians. Most of all, we need to provide a reproducible procedure, a procedure where we use a lesion set that works for almost everybody, I would say, and that everybody understand so that everybody can do it. We need to provide procedures that allow a quicker recovery to the patient and that has measurable outcomes. And here we have to all agree, because I start to see a divergent set of beliefs that our current guidelines said that when we follow up on this patient, we should only detect less than 30 seconds of atrial fibrillation on a Holter monitor or in a loop test or any type of prolonged EKG monitoring. But some societies are moving forward. They are going to look into what is the residual burden, because inevitably we have to recognize not the whole atrial fibrillation can be removed. Can we do better on that? Maybe we can. Time will tell. We need to be flexible and adjust to the incoming technology. We have to be better with mapping. We have to be open to the possibility that pulsed field ablation might allow us to do better compared to prior catheter or cryoablation that we've used for decades. But most of all, I want to make sure that we adopt a multidisciplinary approach. My last slide is exactly about this. Multidisciplinary approach is what we need. We've done this for 15 years in the structural world. It's not one person that is going to win the game. It's the team that is going to take you to the finish line. And so we not only are a team of cardiologists and surgeons, we have to engage our industry partners because they bring us the technology. We need to engage our cardiac anesthesiologists, but the nurse practitioner, if you are in a US setting, or the nurses in your institutions are key. Our lead nurse practitioner was invited to present this model at the last Society of Thoracic Surgeon meetings, because this has worked, at least for us. Our practice of hybrid ablation is entirely run by nurse practitioners. Us as surgeons, we manage, we go to the OR, we follow up the results, but they take care of patients. And their communication model has worked excellently for us. So a team approach is the secret, in my opinion, for the success. And with this, I want to talk about surgery now.
No, thank you so much, Stefano. Great overview. I think the key point here are very strong. First of all is, as you said, speak the language. Second of all is treat your patients. And I agree with you. Tons of patients still goes to the operating room for an AVR, they have atrial fibrillation or coronary artery bypass grafting, and they come out, they don't even have a left atrial appendage clip. And that is irresponsible, I would say, in the current time. Again, good morning. How are you?
It's better late than never. I apologize.
No, come on board. Don't worry. This is, as you know, coffee and talk among surgeons. So don't worry, and thank you for being here. And thank you. It's pretty early in the West Coast.
It's a little early. It was one extra snooze bar that got me. You know.
We all have been there. Don't worry. So Stefano just presented a beautiful series of slides, and we were saying, like, track the journey of the guy that wants really out, couple of years out of his training. He's a young attending. He wants to become an expert in atrial fibrillation. First of all, is treat the patients that comes to your table. It's not possible that still nowadays, 2025, tons of patients goes to the operating room for a full sternotomy CABG. They have atrial fibrillation. They don't even get a left atrial appendage. But most importantly, it's incredible that, as Stefano was saying, people don't even know what is long persistent atrial fibrillation. They don't know what is chronic. They call acute atrial fibrillation terminology that do not make sense. Learn the lingo, treat your patient. Cox Maze is an extremely successful operation, and you need to know how to do it properly. The word maze to me is almost counterintuitive because people get lost in mazes. There is nothing to be lost. It's a very specific procedure that you can learn very well from a sternotomy, something that you know how to do it. And nowadays we have technology, we have catheter, we have energy that can even simplify the lesion set that we are doing, avoiding or almost avoiding to open the left atrium or treating most of the left atrium before opening. So reducing your cross clamp time, if you're doing a CAPS time 4 and a maze, the maze component can really take a small amount if you know how to combine technology together. I've said that we need to move forward because there is a huge patient population that stays on the back of our department and no one treats it, and is a long persistent patient population that could benefit from an hybrid approach. And for hybrid means an off-pump treatment of a series of set lesions for the left atrium, plus a catheter ablation performed by DEP before or after. So again, I'll let you jump in immediately. You've been one of the leaders of this hybrid and minimal invasive. Give us a little bit of perspective. What is hybrid? What type of technologies are out there? What type of energy do you use? What type of techniques do you have? And then we go to Mario. Mario, we will go for your robotic.
No worries.
Yeah, no, absolutely. And I think even before I talk about hybrid, just to kind of double down on what you mentioned, I mean, I think there is it's a language issue when it comes down to treating atrial fibrillation, whether we speak the same language of the electrophysiologist when you're talking hybrid and standalone AFib, or even the same language with other surgeons. And I've, been doing this now for 15 years or so, and I've come all the way around from in the beginning doing some concomitant ablation, calling it a maze, then getting yelled at by people like Dr. Cox telling me you can't call it a maze if you don't do every single lesion, to now understanding if you don't call it a maze, people don't understand what you did either. If you say, oh, I did a left atrial ablation or I did a PVI or whatnot, like they also get confused by that. So then there's this kind of all catch-all concept of modified maze, which in this day and age of encompass ablation, where I think a lot of people are really only doing a posterior box and pulmonary veins, and I think that may be okay. That can be a good entry point for a lot of people in the concomitant world into doing some sort of ablation, because I definitely think that surgeons that don't treat anything, and like you said, there's so many that don't treat any.
I lost you again. Suddenly he's gone. Stefano, Mario, can you hear me?
I can hear you.
Yeah, we can hear.
I don't know.
I wanted to try and while you connect with Gan, I wanted to complete what I think he's trying to tell us.
Go.
We need to do better with the surgical treatment of atrial fibrillation if the patient does have atrial fibrillation. I wanted to just bring a little example of what I do in my practice before Gan comes on. I would say 60% of my patients, whether they're CABG, valve, or aortic, they get some kind of treatment for atrial fibrillation. Okay, I'm not here saying that every patient gets a maze, because that would be crazy. However, if the patient has history of even one episode of atrial fibrillation, he gets preoperatively a Holter test, because it allows me to define whether he has a paroxysmal, persistent or long-standing persistent atrial fibrillation. I suggest this to become part of your preoperative workup. It's not a very expensive pre-op test. It gives you a lot of information. If a patient reports to you that he has palpitation, especially your mitral patients, you know there is a lot of undetected atrial fibrillation. Test them deeply. If they do have even brief episode of atrial fibrillation, please treat them. You will improve their long-term longevity. Even if they have a perfectly repaired mitral valve, at least at the minimum, they will deserve a clip. But I would venture to the fact that your left atrium is open right there in front of you. Treat it. I'm not saying biatrial, but at least the left atrium.
Mario, tell us a little bit about, like, so in the terms of hybrid, and then Gan is going to come back in. What type of techniques are there? What type of surgical option we can offer? And how did you come up in your journey about about your robotic convergent?
So you know what? Well, I mean, when we think about standalone. In fact, how about, can I just jump to a slide?
Yeah,
Does that work?
Please, absolutely.
I'm going to hit present.
Oh, okay.
So you got it, right?
Yeah. You can go for yourself. Yeah. Here.
Okay. So when we talk about, is this big enough for you guys?
Yeah. Can you make it bigger a little bit in your screen?
Okay. Here we go.
There we go.
Yeah, fantastic.
So when we talk about the standalone surgical options, this is kind of the concept. The Cox maze is what Stefano has talked about, and that is the gold standard. I am not by any means implying that any of these others are as good or better. But as Stefano alluded to, there's a lot of people who just don't have the appetite, or the referring physicians don't have the appetite for a full Cox maze. So when we talk about kind of less invasive, there's the TT quote maze, which Dr. Dunnington, I had the opportunity to go watch him do, and is amazing. But it's basically a bilateral thoracoscopic box of the left posterior wall, and then some adjuvant ablative sets and a clip. But then there's what we've kind of worked on and developed, and what we offer mainly at our institution, which is this hybrid ablation or convergent, which is really this combined epi-endo ablation, where from a surgical side, our main goal is posterior wall debulking, as well as some adjunctive lesions that I'll show you in a minute. And you can see these results. But so when I think about, you ask, what are the I'll make this small again for a second. When you ask what are the options out there, I think those are the three things, or the three surgical options we have, two of them being the more minimally invasive.
Mario, can you make it full screen?
Sure.
Thank you.
Yeah, that's great. Yeah.
So as we evolved on our journey, do you want me to just go into this right away? If you don't mind?
Go.
Okay. So when we embarked on this, my cardiac colleagues said, hey, we'd like to start a hybrid ablation convergent program, but we'd also like to manage the left atrial appendage. But my cardiac colleagues didn't necessarily have the VATS or robotic skill set in the left chest. So they engaged me as a thoracic surgeon to help. So we kind of evolved this technique where they would do a subxiphoid kind of classic convergent, which we all know, you put this big probe in a subxiphoid fashion. This is the view you get. And then I would come in and put my ports in the left chest, put a clip on, takes 10 minutes. To increase efficiency, we started working at the same time, and we developed a method where they could do the subxiphoid while I docked the robot. And as we were working, I could see what they were doing, and they would struggle with the views and the exposure, how low, what's the floor. So we kind of started evolving where in an effort to help them, I would make just a floor line from right vein to left vein to say, okay, here's where you start. And then they would march up using this to do everything else. But it continued to evolve. And we had done about almost 60 subxiphoid left chest robotics. And we had really good results, but there were definitely some dissatisfiers. The visualization was awful. If someone had had previous surgery, the adhesions were very difficult to manage from a subxiphoid approach, and oftentimes they aborted. So that excluded some potential candidates. And, we had a not insignificant number of these kind of epigastric hernias from the subxiphoid approach. So as we evolved, we essentially converted to a completely left chest robotic approach. And we've now done about 122. And I'll show you, I know you wanted to get into the technical. So please feel free to stop me at any point during this video, but this is what we've evolved to. So basically it starts with positioning, and I just bump up a patient's left side and let the left arm fall down on the armboard. I take off the armboard pad so the left arm can really fall back and expose that shoulder. the camera goes in halfway between the sternal notch and the xiphoid. So start with that. It's kind of anterior axillary line-ish. Put the camera in. And then start my insufflation. And then I start putting my other ports in. The superior port goes in roughly at the level of the superior pulmonary vein. And I use the long ports because that allows a lot of opening up of the robot. And then I'm just going to stop this for a second. Oops, I'm sorry. Let me go back to that because I think this is important as we're putting in the ports. Because I use all the arms. The robot costs $2 million, so every arm is whatever, $500,000. So I figure we should use every single arm to maximize our return on investment. So, because I know a lot of places only use 3 arms, and I think that diminishes your ability to do things. But what I will say is, so I put these 2 ports right here, and they're probably at the cardiophrenic angle, and it looks like they're going to compete because they're right next to each other. But you'll see as we move on that they really don't because they're working in different planes. So you can position these such that the robot arms don't compete. And then this is the assistant port by which we put the clip in and so forth. So this is kind of the setup from a port standpoint. And then you'll see the robot coming in, and you see these 2 arms are working in different planes. And now
Can you pause 1 second here? And first of all, back again. Thank you so much for reconnecting. We will get back to you in a few minutes. Tell me a little bit, Mario, when you at this point you have the transesophageal echocardiogram.
Oh, sure.
Tell me, because then you have to put a probe, a temperature probe for this patient. So how do you manage?
Our first step is TEE, because obviously if there's clot in the appendage or anything, we would abort, or at least frame shift, maybe convert to open. And I warn people of that. We've only had to do that once, to be honest with you, but we always check TEE probe first. Once the appendage is cleared, we use the Circa probe, which gives you a fair amount of, it's got 12 sensors over about 10 centimeters. So you have some leeway. And I don't bring fluoro in. We used to, and I should probably write a little technique paper about this, but we use a double lumen tube for every case. So we basically measure wherever the double lumen endotracheal tube is, because it's got centimeter measures at the tip. So based off of that, we mark the we mark the Circa probe and insert it to the depth based on however deep the double lumen tube is. And we've confirmed this with a dozen x-rays and fluoro. But so TE probe is in, and then we insert the Circa probe just alongside it. We pull the TE probe back a little bit, not all the way out, just so we don't overheat. Sure. But we don't bring fluoro in for the Circa probe, for the esophageal temperature probe. We just use it. We measure the length or distance to insert based on the double lumen tube and how deep that is.
I love this technique because, it's already a busy OR, particularly if you have also your EP coming in, and now you have tons of, and putting back a fluoro into that OR can become challenging. But
yeah, it's amazing. And, we have a very busy ortho department. So waiting for fluoro can be, so that's why we developed this technique, again, just to increase efficiencies. And I should probably publish it's not a big deal. It's a how-to, but it's super simple. Yeah. We just measure it based on the double lumen tube. It's very simple.
I let you go. Yeah, great idea. So and then you open the pericardium.
Yeah. So open pericardium, very standard. And then I open it. I go proximal and distal. I put a little stay stitch. It just helps. And then this comes out the anterior chest wall, probably at the level of the appendage, roughly. So that gets pulled up, and then it continues to open. And you can get really great exposure as you come up this way. Obviously, you can see the ligament of Marshall already coming into view. And then you can go medially, kind of underneath the phrenic, to even lift that pericardium more. But our workflow is I divide the ligament of Marshall. That's kind of the first step, just because I have the bipolar in my hand. This is looking down the transverse sinus now, and you can see, you can get a great view all the way over to the right atrial appendage. You can see everything. I mean, it's a beautiful exposure. So, and then, we're just dissecting, opening them up stuff. And then my workflow is I start from the top and come down. So I try to put a roof line in, and I know our roof line is not exactly like the EP roof line, but basically go from the right vein and then come across to the left side.
I stop you again. Sorry, Mario. I stop you again.
Yeah, of course.
So at this point, 2 things. You're using end contact as energy, correct? That is
correct.
And do you give heparin at this point? Do you bring your ACT higher? Because some people says you create a lesion, you need to give some heparin. There is a risk of thrombosis. What do you do with that?
That is a very good question. And I know there's some recommendations that say you should heparinize intraoperatively. We have not adopted that. Now, if they're on anticoagulation pre-op, we don't necessarily halt or stop that, or maybe we'll stop it a day ahead of time. But I do not give anything intraoperatively. And, knock on wood, we have not had any events. But we have not done anything, although I know that's...
No, it's your technique. I just want to ask.
Yeah, but I think there's differing opinions on that. And it's interesting. I actually went to a meeting and everyone was espousing how you should give intraoperative heparin. So then a question came up from the crowd, well, exactly how much do you do and blah, blah. And most of the people on the panel said, well, we haven't actually started doing that yet. So I think there's what's said and then what's done. And I think sometimes those two things are disparate. Yeah. So
good. I let you go. I like the video. So
so then I just start coming. Do you want to stop again or
no, go.
Okay. So then I come down from where the ligament of Marshall was divided, and I just come down. You can see these are the anterior left-sided veins. And again, I'm just making a lesion set coming straight down. And I think this is the next part is the key. I'm coming down along the bottom of the left. Here you can see the coronary sinus, pericardium's open. But I think this is where this really excels compared to our kind of convergent. You can open up in front of the right veins if you want. And sometimes I'll do this and I just kind of push the catheter. I'm not necessarily doing anything on the right, but I think this is a safe maneuver if you're so inclined. But this is the big thing. Once you see those inferior right veins, now I just make my floor from right vein to the bottom of the left vein. And you can see these are views that when we were doing our subxiphoid approach, you just can't see. It just doesn't allow for this. And then once I've created my floor, which is what I'm doing here, completing the floor, and you can see these are the probe graspers that the robotic platform affords. They hold the episense very nicely. And now it's like mowing the lawn, just one row after another, one row after another. And I think this approach allows a very efficient. When we were doing it subxiphoid, we had a lot of redundancy. We'd burn and we weren't sure if we were already there. We couldn't see. This allows us to be very precise and move along in a little more efficient manner. And as far as exposure and retraction, I just use these little cigarettes. I've tried everything. I've tried to use the stabilizer. I've tried to use the cardiac atrial retractor that Intuitive makes. None of those, just for me personally, didn't work. So I just use these two little cigarettes. We actually call them blunts because the cigarettes are a little longer. But these come prepackaged in this size. And I just find these to be the most helpful. This is just me screwing around while I'm waiting for the lesion set. But you can see it affords this beautiful kind of view of the whole posterior wall. Yeah. The superior, inferior, all the way to the pericardial reflection. And then you can test entrance and exit blocks if you so desire. Just to make sure that your ablation is complete. And then once the ablations are done, we'll come up for the front. I'll do Coumadin Ridge. And I basically just go as high as where I think the clip is going to go. And then the final step, I put a clip on. Yeah. You've done this 100 times. Super easy. This is actually the easiest part of the operation for the most part. Is just our technique is we just, my assistants at the bedside, I massage it in, they deploy it. And then I typically will amputate the tip and drain it. But this just shows pre and post echo pictures of the clip. And then I leave a Blake drain and, insufflate and call it a day.
Fantastic. How many days do you leave these patients in the hospital generally?
I'll show you that next. How's that?
Go. Okay.
Because I'll show you just because we can do this doesn't necessarily mean we should. So I'll just give you really quick results. We've done 122 of these today, demographics, whatever, all the comorbidities you'd expect. BMIs range anywhere from 19 to 58. 8 patients have had previous sternotomies, and then so this is not a preclusion to doing this. 2 CABG, 2 MVR, CABG, MVR, AVR, so forth. You can see that. But arrhythmia history, most of them are persistent, long-standing persistent. The EFs are good. We've done some giant appendices with left volume indices in the hundreds, but the average is about 48. So decent sized left atrial appendices. But here's where you're going for the operative results. So we've been able to ablate the endocardial 100% of the time. The left atrial appendage, 3 we didn't need to because they had previous Watchmen, and 4 times we weren't able to put the appendage on. 2 had previous CABG where the grafts were sitting right on top of it. I couldn't just safely dissect it off. One had previous severe pericarditis with drains. And again, the adhesions around the appendage were fierce. And one had a big, thick amyloid where I physically could not get even a 50 hoop around this ginormous atrial appendage. So we aborted that one. OR time, 149 minutes. So again, not a super long operation. You could do it expeditiously, no conversions, no need for bypass, no blood transfusions. And for those inclined, I'm a thoracic surgeon, so you can do concomitant operations. So 7 times I've done a left upper lobe, a left lower lobe, mediastinal mass, diaphragmification, a couple of wedges for ILD. So it allows you to do concomitant things if you so desire. This is what you're asking. So we had one patient who we had admitted to the ICU. They had a peri-procedural MI, but everyone else went to the floor. 99% of our patients go to the floor, and the length of stay is average 1.32 days, and the range is 1 to 8. There's always a couple outliers that screw up your average. So 88% of our people go home on post-op day 1. And we have 5 patients who have been readmitted, mainly for heart failure and AF-related possible or problems. So 4% readmission rate. And our complication profile is very low, 6%, and most of the complications are relatively benign. We had no deaths or atrioesophageal fistula, a couple diaphragm paresis, one which ultimately required application, some air leaks, but pretty minor or minimal complication profile for the most part. And then again, if we're going to do this, and Dr. Schena, and I got to applaud him because he's been fantastic of ensuring follow-up on these patients and is really diligent, and he'll call these people at home and say, you better get in here and get your Holter and so forth. He's been great at doing this. But our mean follow-up, so there's always some people lost to follow-up, but in the follow-up so far to date of 104 patients done completely robotically, the LA exclusion is 95% with no clip failures, and the 4 I already told you about. And 83% of those are off their anticoagulation. Some still are on it for other reasons, but 83% are off anticoagulation. Follow up at 3 months, 12 months, and 24 months. You can see the denominators here, 87, 60, and 19. So freedom from AF at 3 months is 75%. At 12 months in that cohort is 70%. And we have a couple out to 24 months now, which is 68%. And 2/3 of these patients are off the antiarrhythmics at 12 months. Wow. So, and these are just what we can show. And I think this is important as we have this collegial relationship with our electrophysiologists. We need to look at the maps. We need to understand what they're seeing and what we're seeing and what we have to offer. So this is a patient who came to us that we mapped. This is we'll call it a de novo. So he came to us, we did our hybrid ablation, then he went to the cath lab. So this is after we had done our part before they completed the lesion set. So you can see we did a really nice job of ablating the entire posterior wall. And really all they had to do is touch up this area up here. And this is the completed hybrid procedure. They appreciate this, but I think we need to look at these maps because it tells us maybe what I'm missing, what I can do to improve my technique. We really have to have this dialogue with our electrophysiology colleagues so we can understand how to improve our techniques and do what they need us to do. I'm going to show you one other map because this is the newest trend. So this is a person who had persistent atrial fibrillation, went to the electrophysiology lab and had PVI and PFA of the left posterior of the left atrial posterior wall. So this is them before they did their endocardial ablation, and this is them completing their procedure. This is their map, and you can see they did a fantastic job. At least endocardially, it looks perfect. They did a great job. Unfortunately, this patient rapidly recurred with AF, and so he was sent to us after this. So we did an intraoperative mapping, and here's what the left atrial, the posterior wall looks on the epicardial side. You can see a fair amount of voltage, a fair amount of activity, and then this is our mapping after we completed our hybrid. I think this is important because it really demonstrates that whole endoepicardial dissociation. And again, I think this is why this multidisciplinary approach works and is complementary to each other. So I didn't want to take up too much time. I just wanted to show these things. This just shows, I think robotic hybrid ablation is a safe and efficacious procedure. And, I don't want to take up too much time on this. So I'm open to just talk and chat.
I love that. No, but yeah, first of all, kudos to you, Mario. Like I really have a lot of appreciation for what you have done. You came in with your own, point of view that were fresh eyes as a thoracic surgeon and with your skills. And I think, TAVI has been invented by a cardiologist. And like in one way, sometimes you need someone else that is not in the too much into the business of I've seen too many surgical AVR or I've removed too many calcific leaflet to come up with an idea that can be disruptive. And I must admit, I think that what you are bringing here in the table and what you have developed as technique is huge. And I'm looking forward to do my first one. As I told you, that was the reason of organizing this event is I'm planning to do my first one on the 10th of February. And I want to learn from you the features, the uniqueness of the techniques. And I really kudos to you for what you have done. You've been extremely successful, in my opinion, together with Stefano, to partner them and follow up with them, these patients and treat them together. Gian, you have been one of the father of this concept of hybrid. You have been one of the really, and I don't wanna call you grandfather of this stuff. You are
way too young for that. Yeah.
Exactly. But tell me where this one came from in your point, and what is your technique? We will go for a technique immediately, but tell me where did you came up with the idea?
Well, I mean, to be honest with you, it wasn't me. It was Mark Lemaire. You know, I happened to be at the right place at the right time. This is the entire story of my entire career, basically. I was, whether it was med school, general surgery, cardiac surgery, but Mark Lemaire came to University of Virginia when I was there and started working with Gaurav Ahlawati, because our EP, Srijoy Mahapatra, who's kind of moved on to an industry role now, was interested in something better than catheter ablation. And so they decided, and at that point it was kind of same day hybrids, which, was basically, well, we can do better than catheter ablation, repeat catheter ablation. So there was a paper, it was probably in around 2010 or so, 11, where Srijoy showed, well, if you stage it for people that had failed catheter ablations, if you just did another catheter ablation versus try to do a hybrid, which in their mind meant do a surgery and then a catheter, not only did you have much better success rates, but it also is a lot easier for the EP and faster. Obviously, Mark over there in Belgium they do same day hybrid. So I evolved in the beginning trying to do same day, and AtriCure was running their deep trial, and those cases were taking 8 hours. Right, it would take me 4 hours to do a VATS part, and it would take them another 4 or 5 hours to do the catheter part. And those patients were really struggling, on the ventilators, whatnot. So then I said, oh, why don't we just split it in the same hospital stay? I'll do surgery. It takes me, still took me 2 or 3 or 4 hours. Then 2 days later, make sure they're doing okay, they go to the catheter. And they did better. And then ultimately I decided, I had a couple complications, actually. I went back to doing same day. I moved hospitals, went back to doing same day. And there was one patient that had a stroke. And there was another patient that, I did my part, then they would go to the EP lab, got ablated, and shortly thereafter put all kinds of blood out of their chest tube. And I had to go back and do a little kind of left knee thoracotomy, kind of threw some Hail Mary stitch up in the roof, area, got it stopped. And the EP swore up and down that he never perforated the heart, even though it was clearly an EP perforation. And everyone in the cath lab was saying, we saw the mapping catheter go down right there. So I was like, all right, this is crazy. We're basically mixing 2 potential complications into one procedure. It's harder for the patients to recover. Why don't we split it out by 6 months? Well, it turned out to be financially beneficial for the hospital to split it out because it was 2 different DRGs. But also, more importantly, we also then presented a poster at HRS that showed if you split it, you actually had better outcomes, rhythm outcomes, because if the maps that happened right after the surgical ablation were often faked out, right? There was pseudo block, there's edema, and the maps would look perfect. And at 6 weeks, that perfection would disappear, and they would find it would unmask kind of some real areas that they could actually touch up and fix. So that's kind of why I got into the hybrid mode. And yeah, I can kind of go through my slides because I talked a little bit about it, but it's definitely been evolution. Guys, I'm really sorry about the technical. We're having a big storm here, and I think I lost internet for a minute. And a big storm in California means about 7 raindrops hit the ground. So that's what kicked me off.
No, these are spontaneous meetings. So again, this is our, you see, like PowerPoint is not important here. Is your contribution. So please.
No, absolutely. Well, so, and again, I want to kind of show the video, but I'll go through these real quickly, but 1,200 cases. This is VATS. I mean, Mario, your results are outstanding. One of my main, and we can get to questions and talking about it later, but the real question is around adoptability and how can you teach other people to do these things. All right, you can go on. That's my hospital in Napa, and everybody should come visit. This is a list of EPs I just scratched out once on an airplane of the different EPs that I've worked with, and I kind of started breaking them down. Well, okay, some of them are academic, some of them are kind of like me, like community doctors, but they still talk at the podium every now and then, and sometimes publish, and then they're pure community EPs. But what's interesting about the list of the EPs that I've worked with is it's a pretty even split, right, between EPs that are just purely at the university versus all the way through. And these are ones that, for whatever reason, have decided along the way that catheter ablation isn't enough. They wanted to have something else to offer their patients. There's lots of kind of talking points for that. And this list has definitely shrunk in the last year because of PFA. And I think it will swing right back to us. I mean, there's no question. Everybody is convinced PFA is going to, solve all the world's problems, just like irrigated tip catheters or firm ablation or pressure sensing or all of these things. EPs have been able to master the concept of marketing to the degree that they convince the whole world they can fix it with a catheter ablation. But then they realize, no, we can't. Let's go on to the next one.
It's like the new drug-eluting stent, no?
Absolutely. Yeah, there's no one's ever going to have a cabbage again.
No more cabbage. And then, like, you see that effectively it's not exactly the story. So.
No, exactly. So, this was obviously the Dutch and the Belgians put together just a meta-analysis, and it's pretty clear the hybrid results are better than, catheter ablation results. So that kind of points me towards hybrid. Keep going. And then, this is kind of where my ports probably look somewhat similar. If you get all the robot out of the way and all the robot arms and coverings out of the way, you basically have 4 ports on each side of the chest. And, this lesion set, anymore, I don't really do that many. I'll do a mitral line or a partial mitral line, but I do it anteriorly. So more the Dallas lesion set.
Just 1 second. So you put first, you go from the right side, correct?
Yes, I start on the right side, and when we go to the video, you'll kind of see from the inside. I don't really show me putting the ports in, but I start on the right, and then I go to the left. Now, with my technique I'd use right now, which we call ABC or all bipolar clamp. There's actually a funny story because I actually call it the double Dutch technique because I thought it was like 2 kids skipping rope. I thought it looked funny. And then I was told by my Dutch colleagues that there's like some sort of, somebody told me there's a negative connotation to double Dutch. And I didn't really know what that meant. And then and so I said, okay, fine, let's call it ABC, all bipolar clamp. Well, I've since found out that, do you guys know what double Dutch means in Europe?
No, I'm European, and I'm very proud of it, but I don't know what a double Dutch is.
My good buddy Antoine Driesen in the Netherlands explained it means if you have sex while the girl is on the pill and you're still wearing the condom, which for me, I thought, you know what? That's fantastic. We're really safe. We're super safe. But anyway, we'll call it the ABC technique.
I see. This is very Urban Dictionary stuff.
Right, exactly. So, but yeah, with the ports, I say the port placement should take 1 minute. And honestly, the port placement is, the first port is blunt. The next ports are, if there's no adhesions, I don't necessarily watch it come in.
I ask you, are you dual lumen intubation or single lumen with block?
Dual lumen intubation. I think that is a little bit easier and less cumbersome because sometimes I do go from the right side of the body to the left and back to the right and to the left.
Yeah,
that can happen on more challenging cases, and so it's a lot easier with a dual lumen tube.
Yeah,
I always have an A line, and then I just have a triple lumen up here. These patients are all going to go up.
Do you put any lift on the patient?
I have bags underneath them, and I used to, deflate one, inflate the other one, but now I just put them both up, and so their whole chest is raised a little bit, and I just turn the bed. I found that it really didn't add a whole lot of advantage for me to kind of deflate, inflate. I just rotated the bed, and that seems to do just as much for me.
and I play the video.
Sure.
Right
so I didn't really show the ports, and I didn't show the pericardial opening, but it looks exactly, what Mario's showing with the robot. We're on the right side of the body, obviously. This is a critical step, I think, on the right side, and this is why I still like going bilateral instead of doing just left only, is this fat pad, which, whether GPs matter or don't matter, like this one is definitely chock full of fat of GPs, and I think it really can be important as far as the actual ablation side. So I'm using the lighted tip dissector. I passed all the way through the oblique sinus. I'm going around all 4 veins. Okay, so I'm looking through the transverse sinus. I'm above the SVC and below the aorta. So now this red rubber catheter encircles all 4 pulmonary veins, and I'm bringing the clamp through the uppermost port, and it's going from right to left, because basically, ultimately, I'm going to have the 2 clamps coming from each side. This is the double Dutch, or the all bipolar clamp. This is instead of using the linear devices like the Cool Rail or the MLP. And there's, definitely a little bit of nuance to making sure you don't poke a hole in the dome of the heart. I've done that twice out of a couple hundred cases now. But you can clamp, and it really doesn't make it all the way across. That's why you don't have total inflow occlusion. You don't lose your blood pressure entirely. If it's a small atrium, it will, and so you just back it up a little bit. So I basically just do from right to left, and I go across as a box, kind of as belt and suspenders. I also always do the PVI as well. In theory, you could just go right to left and left to right, like the Gemini European Medtronic device. But back when I used the Gemini, if I supplemented with the PVI also, it made a big difference. I wanted to get away from this, having to go around the veins with a lighted tip dissector, because this is the step where people get into trouble. This is the step where people poke holes in the back of the left atrium. But because I know how to do it, I'm pretty good at it. It only takes me a few minutes. I keep doing it. But I think this is one of the weaknesses. This is one of the benefits to the convergent, is you don't have passing hard, rigid structures around the veins where you can potentially cause problems. So after I've done basically this partial box and I've done the right PVI, I just put a red rubber catheter in and I stuff it and close it. And that's all I've kind of done on the right side.
Yeah.
Close it with this cool fisherman's knot that Victor Rodriguez told me how to do. And then I go to the left side. So now I'm back to just similar to what Mario just showed. I'm on the left side. I'm opening up the pericardium. I just use Bovie on top of an endo-Kittner. I have 4 ports because my assistant's holding the camera, but he also uses that extra, this extra endo-Kittner here to hold the appendage away, whatnot. Big, robust ligament of Marshall. I always divide the ligament of Marshall. One, it kind of helps with some exposure, and then maybe there's some value to ganglionoplexi ablation. I don't know. Fish the red rubber catheter out from the sinuses. So that was from the transverse. And I'm bringing both of these out through the same port, the upper port, and then I bring the clamp in, and now I'm going to come across from left to right, just like I did right to left. And it's going to effectively be a complete box anterior to the pulmonary vein. So like I said, theoretically, you wouldn't even necessarily need to do the pulmonary veins also. The lower jaw is attached to the red rubber. I'm just not worried about it. The upper jaw is what I'm really trying to more visualize. I'm just pulling it across. Same thing. Now, with each ablation, whether it's the pulmonary veins or this, I do about 6 to 7 doublets. So I call them Damiano doublets because he had that paper saying it was better to step on the pedal twice than once. I don't necessarily believe in the what the monitor's telling you on impedance and conductance. It's just more like, okay, I think 6 doublets has got to be enough. And based on everything I've done, that does seem to be the case. Now I've gone around just the left veins. I'm going to get the clamp around the left veins. And, different body habitus is different size. Guy I did yesterday was 400 pounds. And, different body habituses require different. Sometimes you have to adjust your ports a little bit. Sometimes you have to resect some fat, get it out of the way. There's a lot of variability. And then I put the clip on. And for a long time, I spent time putting a line up to the left atrial appendage. What I found with this ABC technique, usually my ablation line is kind of going up onto the base of the appendage anyway, so it doesn't matter. But 2, I've had very, very few, maybe 1 patient that I can think of after 1,000 that had that had a flutter circuit because it was going around the base of the left atrial appendage. The flutters that I encounter are almost always, you know, perimitral flutters, which are going to require the EP. You know, at times, if it's a redo, I do a lot of debulking on the anterior mitral line, and I'll go basically from where the clip is up to the aortic annulus and let them finish it. If it's a de novo, and this patient must have been a de novo, I won't do a mitral line. And I learned this from Mark Lemaire also. Like, if they've never been ablated before and they have a healthy anterior wall, you're almost doing more problems trying to do a partial mitral line than not. I'll just run through a couple, and then we can kind of talk about it. I know since I delayed us, we're over time.
No, go for it.
Okay, so so this was just our paper in 21, and a funny thing is, you know, this doesn't reflect any of that technique I just showed you, but you know, we looked at 455 patients. You know, almost all of them were non-paroxysmal. Most of them very similar types of demographics that Mario had. I looked at it; they probably could have just, you know, overlaid them, and they would look similar. You know, 5 years of AFib, high, kind of 4 centimeters, almost 5 in size. And we had basically at 12 months, 87% in normal rhythm, 81% off AADs. I also would commend you on the follow-up that you have. I mean, I think we had pretty solid follow-up, but that is one of the biggest challenges, and particularly for me, where I live in a rural area in Napa, California, and a lot of people are coming from far, far away. It can be a challenge to get these people to still follow up for rhythm monitoring. But all right, let's just whip through the next couple here real fast. So we wanted to show, okay, in heart failure patients, those that are less than 40% EF, you could have good results as far as your ejection fraction rise, and it did. Went from 34 to 46% with still the same results. Next one. Prior cabbages, Mario said, so I did, at this point I'd done 23 that had prior cabbages. I think I'm up to about 75 with prior heart surgery. They're a pain. They're real. They're not ones you would want to try with this technique in the first 100 cases, or certainly the first 50 cases. And I don't have a slide on the concomitant lungs, but I also agree. I think I've done 11 or 12 where I've done a lung resection, and I do thoracic as well as cardiac. I've done concomitant lung resections, and they've done well. Next slide. This is quality of life. We just showed very, very good quality of life improvements using the affect score out of ways. Keep going. This was just my left atrial appendage study. We brought 100 patients back-ish to basically that were over a year after having their clip placed. Most of them had been placed, or at least well over half had been placed VATs. Some of these were concomitants. But, you know, all I wanted to see was, did it migrate? Everyone said, oh, the clip, if they had a bad clip later on, they said, oh, it must have slipped or migrated or whatnot. It doesn't migrate. Basically, I'm not always perfect, meaning we had a few patients that we had a stump. Obviously, there's never a leak, and I cut my appendage open like Mario showed as well. But if you had a stump, that stump was there at the index operation as well. Sometimes anatomically, it's just flat out impossible to get to less than a centimeter. It's rare, but every now and then. But what I was happy was out a year when we brought them all back, did TEEs. You saw no change from what you had intraoperatively. So that was the key for me is knowing, one, just how important it is, because there's other studies, you know, Laccaretti out of Kansas showed that study showing something like 30 or 40% failures of AtriClips. And that's not a failure of the device. That's a failure of the technique, obviously. And to be clear, I've put on now, it's like 3,000 AtriClips. If you put it on, you know, from the VATs and the opens, I've clipped everybody prophylactically, even on anyone I've ever done heart surgery on. So, you know, I should have the technique down, which means that if you still have a 4 or 5% failure, like, that's probably where it's going to end up. You know, I don't think it's ever going to be 100% perfect clip, but there's a whole nother argument on what's a 1 centimeter stump even mean, you know, or
sure.
one
Exactly.
All right, I'll whip through these last couple also. So with AFib, obviously our surgery goal is safety and efficacy. It's the adaptability. It's crushed us, right? From the beginning. Jim Cox is like, what the heck? I got this procedure. I invented this thing. It works great. If people would just do it, nobody did it because it's really hard to learn how to do. Next slide. Everything has been kind of the same in the last 15 years for me. I mean, this double Dutch technique is new, but everything has been the same except for kind of the ablation part. You know, as far as the technique and how we do it. We'll keep going. Now, this is a slide that basically looks, you know, through my career of the changes that happened. You know, I talked a little bit about doing same day, splitting it out by 6 weeks or whatnot. I've used cryo. I've done that same thing with the EpiSense that you did with the robot, where I wrapped it around and actually had some pretty nice results. But I think with the robot, it's a little bit easier for you. It's more maneuverable. I didn't blade the posterior wall, but I used it kind of mostly for roof and floor lines, but I've also used it on its own just to create an entire circle. You know, so every whatever, a couple hundred cases, I feel like I have to iterate. Now, you asked about that anticoagulation. I used the Fusion for 284 cases, and it was a great ablator device. And frankly, you know, it's the EpiSense on steroids a little bit. My problem with it is that I had about a two times higher stroke risk. I think I had about 4 strokes in that 284, maybe 4 or 5. And when I got to the point where I was kind of thinking, well, every time they went to the recovery room, I was thinking, okay, just make sure they wake up and don't have a stroke. Like, that's when I know, okay, I got to stop using it. We went back and forth with anticoagulation. We did full anticoagulation, whatnot. I don't do any anticoagulation for my technique now, and I haven't had any strokes at all with this technique now. And so I do feel like that's good. Now, EpiSense infusion, I don't, you know, that shorter effector arm, do you need to have anticoagulation or not, is totally, who knows? You know, I think that's a real question. All right, we can go to the next one. You can go on. That's just the actual paper. I want to show the complication rate. So if you looked at it, so if our success rates are somewhere in the 80-90 range at a year, well, it drops down to 70-80% at 2 years, and 3 years it's kind of 60 to 70%. You know, I think we're probably, you know, and that's by the strictest definition with pretty solid follow-up. I told patients clinically, I said, by research definition, out 3, 4 years, 5 years, probably, it probably levels off, and you probably kind of research-wise are at 60-70% success rate. But from a clinical standpoint, 95% of patients are in sinus rhythm almost all the time and off meds, right? I mean, that's really the number. If I compared my techniques, like that was basically, you know, using 2 MLPs for roof and floor. I did a handful with the Synergy. And then now I'm well over 200 on the ABC. All of the demographics, everything was the same, but hit the slide again, except for the time, right? So I went and took my procedure length from 105 minutes. Jim and I helped a little bit, 72, and right now I think I'm kind of closer to about 60, 2 minutes. So it just goes to show there's obviously a major learning curve. Time comes down, but shorter time, but also, PVI rate shouldn't change because I'm doing the same thing I've always done. But my posterior left atrial wall at 6 months is, go back up one more just to show, 91% of them have a quiet posterior wall, as opposed to when I was using the linear devices, it was 64%. Go to the next one. Now the AtriCure guys came up with this really nice report, and I don't know if you guys are using this or not, but I would definitely highly recommend them talk to their reps. Where, hit the next slide, hit next slide. It shows exactly the EP, kind of where you put your lines, and then there's a little description of how many times you hit the clamp, and then in the kind of, I know it's too small to read, but in that box in the bottom right, it just gives kind of a narration. You can have pictures of the pre and the post clip. You can have pictures of the pre and the post rhythm. But it's really, really nice. EPs and even general cardiologists respond well to this. They know what you did. And I personally, if somebody does have a recurrence or any issues, I just send it as a text. And so I know who it went to, and I can immediately pull it up and say, okay, what did I do? So I think this is a really good way to try to help keep track of, because there is little minor variations that happen, right? Sometimes, Mario, you pointed out, like wrapping around the right veins. Well, probably sometimes that's fused up and you can't open that little window, or there may be another time where you just want to comment on, there's one common vein on the left as opposed to, something else. So I think reporting and communication is a big part of building programs. And, I apologize again, I came in late, but that language of being able to build programs is being able to speak the same language as the EPs, right? And that means, using the right kind of using the right terminology, but also, understanding that their EPs, in some ways, can be kind of full of it also, as far as what they think they're doing, right? Right now, they're doing a lot of PFA and getting these perfect maps, but are we really sure if a voltage map shows you something, a propagation map is going to show you the exact same thing, right? I mean, there may be all kinds of nuances, but what I found in the EP world is that mapping, the way they do it now, democratized it a little bit more, and there's a lot more procedural EPs that think like surgeons than I think there used to be. There are very few surgeons that think like EPs. All right, let's hit the next one. I'm almost done here. I know those are kind of maps like we see, like Mario was showing, where you have nice quiet posterior wall. Like on the right, that's a Cardo map. On the left, that's an Insight map. Normally, I actually wouldn't even advocate, if you had this on the left, this really purple anterior wall, I wouldn't even advocate doing a mitral line because it looks so healthy. Like why start, screwing that up with more ablation lines? And I would say, unless they've had atrial flutter. On the right, this is more of an example of the cases I do at one of the hospitals in Redwood City. The average patient has had 4 ablations, average. Okay, so that means plenty of them have had 5 or 6. And they almost all have some degree of left atrial flutter. So working with Chad Bart there, he came up with this SAMI, Sequoia is the name of the hospital, Sequoia anterior mitral Y. I do my same lesion set as always. That's what I tell the patients. I said, I'm a one-size-fits-all kind of guy. I do the same thing on every person. It doesn't matter, mapping, whatnot. But what he's going to do is he's going to connect basically my posterior wall isolation to the anterior mitral annulus, probably right at around A2. And he's going to come from bilateral superior pulmonary veins to the anterior mitral annulus. And that gets you away from all the coronary sinus nonsense and having to worry about ablating inside the coronary sinus. So we've had high success rates there. All right, another. Okay, so this is about 6-month-old data, but basically that's what it was. I haven't had any deaths. I have had a couple perforations. We've had very pretty good solid follow up on this cohort. Keep going. At this point, it was 97% at a year, but it won't be that high. It'll be somewhere in the 90% range. The sternotomy was as I was, basically teaching my partners how to do this. I personally, and not that I won't, but I personally haven't had a sternotomy in a long time, years and years. As far as using this new technique, I poked 2 holes in the dome of the left atrium. I put them on fem bypass and put a stitch in and finished the case. And frankly, nothing really changed other than my heart rate went up really high for a little while.
So you were in atrial fibrillation, probably.
That's right. And it's just always a reminder. This is why we have pump backup. And, Mario, I commend you. I didn't hear what you said. The detail is on, it looks like you guys haven't had to have any crash-ons or sternotomies or pump, but obviously you're ready for that when needed. And that is the barrier to, I think, most thoracic surgeons taking it on. At the same time, the barrier to cardiac surgeons doing it the way either one of us doing it is they're not used to working on the scope as much or from the side, unless you're truly like Gianluca, a robotics guy, and robotics, I think, will really help push us forward. All right, maybe one last slide. Oh yeah, so this is just kind of my mnemonic for them, and it's not totally accurate, but it's just easy to say. This is the rule of 2. This is a 2-stage procedure. I have to constantly remind them that because they always, do I have to come back for the second stage? Is there really, why is the second stage? I have to constantly remind them because I think there's really value and durability. I don't know for sure, but I think there's really value and durability. I say 2-hour operation, 2-night hospital stay. Mine go home postoperative day 2 as opposed to yours to go postoperative day 1. I'm very envious of you that you can get them home in the first day. I pull the tubes out. I have 19 French Blakes and I pull them out day 1. And honestly, maybe some of them I should just send home because most of them I just say, get up, walk around. A lot of them are going, hours and hours away. And so I usually kind of want them to stick around for an extra day. I say if you work full time, plan on being off work for at least 2 weeks. I say 2% risk. I say from a mortality risk standpoint, I haven't had a mortality in the last 200-300 cases, so it's come down. But it historically was about a 1%, and then you had 1% of other bad things that could happen, and then it's usually 2 months between stages. All right. And then, the 2-week rhythm monitors. So my last slide, I always use this one as my, when I'm kind of presenting, because it makes me laugh so hard. My PA and I always enjoy this part of kind of cutting the appendage. And, I'm a big zombie film guy. I love watching zombies. So you love it when the blood hits the screen, so you can hit the button one more time. And that's where I put my summary slide on. And it always gets a big, wait, there should be words that come on after the blood hits the screen. Oh. Actually, you don't have to hit. So basically, who should you do it on when you can't do catheter ablation? We don't call them catheter failures. We call them non-responders now, right? So if they haven't responded to catheter ablation, left atrial appendage occlusion is essential. Now they're putting Watchman, and a lot of patients are doing catheter ablations on. So this indication will drop because they're just doing so many more Watchmen anymore. And then obviously, if oral anticoagulation is absolutely contraindicated, I don't have any problem doing these with no blood thinners before or after. Or clearly if hybrid is preferred. So, my big thing for patients and even non-EP cardiologists is patients should know that they have options, whether it's convergent, whether it's hybrid, whether it's open maze, all of those things they should know about them before they, one, AV node ablate them and pace them, or two, just quit on them and say, yep, sorry, you're just stuck in AFib forever. So sorry to be a little long-winded.
No, it was awesome. A couple of questions, and I love it. Like technically, I saw Mario and Gan. You both open the left atrial appendage. I do a lot of clipping of the left atrial appendage, standalone, robotically. I never open it or even sternotomy. Should I? Do you think it's better?
Well, so I'll start. I'll see what Mario has to say. Two things on that. One, I've started to use it as my LV vent site, which I think is a really, really great technique. You don't have to put any stitches in anything. You don't have to put the pulmonary vein. You just cut a little hole in it, drop the vent in, and if you're doing, aortic root, aortic valve, whatever, it's a great place to have the vent, and then you just clip it at the end. The only reason I ever left it open was because there was a case early on, 10 years ago, that I'd opened it for some reason or another, clipped it, and thought, I'll close the hole. And at the end of the case, it wasn't bleeding. I pulled the heart over and I looked and I said, looks fine. So from then on, I never actually bothered closing that hole or worrying about it. The reason I opened it was because you'd get an occasional echocardiographer telling me that they thought there was some sort of maybe leak or, I think it's still cut. They would be seeing a cut of the pulmonary vein and, I think there's a little leak through the clip. And I say, all right, I'm just going to open it. There's no frickin' way it's leaking, one. And two, from our general surgery period, we all knew if you had a bad car accident or a gunshot or something and you had a duodenal injury, your kind of bailout if you couldn't fix a duodenum was just pyloric exclusion, right? Put a staple fire across it. And I was always fascinated by the concept that that's all you did. And you knew it was just going to open up one day. Right. And so in my mind, I thought, well, maybe that's why Watchmen fail. Maybe that's why lariats fail. Maybe that's why when surgeons, why is it when surgeons do a perfect purse string or even oversew, like a lot of people still do when they're doing mini mitrals from the inside, why does it open back up? And it's got to be because there's some sort of edema that goes down. There's some sort of atrophy of the tissues, and then it opens back up because it's pressurized. And I think if you open up that appendage, if you just did a regular purse string and open the appendage, I think you would never have a failure. You're not going to have a delayed opening to it. So that was kind of my rationale, was that it probably minimized your risk of it ever reopening again. But I also just kind of like the aha factor and flair of cutting it.
Yeah, I agree 100%. I love watching the squirt of blood and then all of a sudden it's quiet. But it's interesting. I had one patient before I started routinely opening them that did everything we did, went home, came back 3-4 days later in pretty rapid AFib, and they wanted to cardiovert him. So they echoed him and saw a bunch of clot in the appendage, which obviously you're going to have clot in the appendage because there's a clip there. And they wouldn't cardiovert him. So it blew my mind. So I was like, this is crazy. So I just started opening every appendage. It was Yeah. It was
Stefano,
it was
do you
amazing.
That's another very good reason. Yeah.
Stefano, do you open your appendage in a sternotomy when you do your sternotomy?
Yes.
Appendage?
So it's important to underline this concept. When I ablate surgically, I mostly do a Cox Maze 4. But while by training, we used to amputate the appendage and then oversaw the stump, and now I clip them. However, before clipping them, I do my Coumadin ridge. So I make a hole in the appendage and I go towards the superior pulmonary vein. So by default, they're all open. Then I put a clip at the very base, but I don't close the rents. Right. So
I do the same in sternotomy. Like when I do a sternotomy, I do exactly what you just described. I open the left atrial appendage, I put the RF inside, and I go to the superior pulmonary vein to do that line. But I think that it's interesting. I never done it in a when I come robotically. I should consider. But
yeah, I mean, I don't know that it really adds any benefit, but I think Mario's point is a really good one. That it could trick people into thinking there's clot there if they did it to you when there's not. And I think the main thing is there's no downside opening. Now, I say that there's probably been a half a dozen cases out of 1,200 where it was kind of still oozing through it. And I either put a second clip on or I fired a stapler across. So it's not out of the realm of possibility. Yeah. But what I've never done is like cut it and had it gushing, right? It's more like, it's just like some little oozer. It's a low pressure system. We get away with a lot in the left atrium because of that.
I love it. Well, I think it's time to wrap up. And, we've been an hour and a half. I had some questions that we got. The first one is about pain. And do you guys, what do you do for pain? Do you use block? Do you do cryo? Do you do a combination of both? Do you just not do anything? What's the game there?
Mario, you want to start?
Yeah, so fortunately from our port placement, it's more anterior, and these ports tend to hurt a little less than if I have people in a full thoracotomy and I'm going all the way posterior. But I'll do a combination of local, occasionally I'll block. I have done these in a lateral decubitus position as well. The setup's a little different, but it's doable, depending on if I'm doing lobe at the same time. For those, I cryo all the time because I think the further posterior you go with the ports, the more they hurt. But pain is not a huge issue. Yeah. And Gan alludes to it. 2 weeks is basically what we tell the same thing. It's amazing how much better they do. It's probably half because we're more anterior. The interspaces are bigger. It's a relatively quick operation, so there's less pressure on the intercostals. But I use a combination of local and occasional cryo, depending on kind of where things are at.
Yeah, from my standpoint, I've done everything. I've tried cryoing. I used Exparel. I've used regular local. Like I've kind of been more diligent, less diligent. I used to squirt like steroids and Exparel like inside the pericardium. And frankly, none of it mattered. Like as far as what hurt them is what, and it's ironic, but those little soft 19 French Blakes, as soon as they come out, like most of the pain goes away. Some of that is expectation. So all I do right now is I literally squirt like, I don't know what it is, probably 40 cc's of marking into the chest tube, just into the pleura. And I sometimes give a little local kind of into the port sites. I still don't think it matters. If I do it on one and not the other. Yeah. So I just tell them, look, here's the deal. Tomorrow morning, you're going to hurt. You're going to have a PCA, Toradol, Tramadol, Tylenol. Like you're going to have all these things. Tomorrow when we take the tubes out in the morning, 75% of your pain is going to go away. And magically, these aren't the droids you're looking for, right? Like magically their pain goes away when we take the tubes out. I would say 50% of my patients tell me they never took a pain pill when they left the hospital. Good. But the other 50% cried total bloody murder. And so it has to do with what is their starting pain threshold. But I've really, again, if you want to take the time and do cryo, you could do it. Taking the time to do cryo to 4 different levels in addition, like that would almost double my procedure time. And so it's kind of hard for me to get excited about doing that.
Stefano.
I wanted to add a little concept to the pain management. I think, Mario and Gan are way more experienced than me, but if you have a robotic, the pain management is the same for the procedures that you do that are non-ablation procedures and whatnot. Those patients that have long-term pain in our first early experience are those that develop pericarditis, pleuritis. And we started to put them as a protocol on either colchicine or indomethacin. And Mario has developed this perfect protocol with our nurse practitioner. Those patients have less inflammation, tend to have less discomfort compared to just the intercostal pain from port insertion.
I completely agree, and we send everybody out on colchicine for 2 weeks also. And I tried it with steroids, and blood sugars fly up, and some people go crazy, and it was just, and white counts happen, so people get all nervous about. So I struggled with the steroid thing. I think having some colchicine or some sort of pericarditis mitigation is really, really important. I agree with that.
I do the same. I cryo everyone. I put everybody in colchicine. I do the block at the end with my anesthesiologist. I also tell you one trick that I do even for my sternotomy, chest tube pain. If the chest tube output has been less than 100 cc per hour, meaning if they are not bleeding, you clamp the chest tube. Okay, you elevate the chest tube with some towels, and you inject the chest tube after you clean it with some chloroprep. You inject with bupivacaine. 20% bupivacaine. You create a syringe of 10 ml or 20 ml, and you inject the chest tube. And then you come out and you put a tegaderm on top of it. This is something that our PA are doing.
You're saying you're just putting the bupivacaine into the chest tube. Yeah, that's what I do. That's exactly what I do also. And
I love it. And there are some patients with this tube pain. The pain goes away almost immediately.
That's interesting. So we do it intraoperatively. I haven't done it afterwards. I like that idea. I want to try that.
Keep doing even after like every basically 4 hours, 6 hours, you can inject them. And there is like a 70% of patients that they do very well with this chest tube pain. You need to give the name of Osenian technique as my wife's surname. She's a cardiac anesthesiologist. She taught me how to do it, but it's a great technique. Like the Lela technique, it's great. And you inject them, and they do better, and you don't have to give them tons of opioid or other stuff.
Oh, I definitely want to try that. I think that's
because pain is complex. It's not one thing fits all. You need the cryo, you need the block, you need the chest tubes, you need the colchicine, you need multiple agents to do it. And a couple of more questions, and then we close.
Well, just to follow up on that real fast, I pulled the chest tubes out, for a little while, like right at the end of the procedure, like in the PACU, if there wasn't really anything coming out. And I just had I don't know, all it takes is 1 or 2 lung dropping down and having to put a pigtail back in or something that you're like, okay, no way I'm not going to do that.
Yeah.
But I think that's why I sent him home post-op day 2 instead of Mario's post-op day 1, is because they don't believe that their pain is going to go away when the chest tubes come out. And so they're like, there's no way I can go home today. And by post-op day 2, they're like, what am I doing here? Why am I still here? So
very true. Very true. Mario, Massimo Baudo is one of my research fellows, a brilliant young surgeon growing up in the field. And he's asking, right side, you showed your way of what do you do? What are you thinking the evolution of your technique will be?
Well, so I actually went out to see Gan, and he was a gracious host, and it was incredible. But in an effort to try to incorporate maybe a bilateral robotic technique, I will say some of them, Gan's awesome. And some of the moves he made were a little butt puckering while I was watching him. Like, I'm not sure what he does is translatable the way you get that dissector and clamper on there. But no, I think the concept is, we'd like to do, for people who have no endocardial options, I think that's the evolution of what I do, is literally start on the right, do everything you do, but I would do it with the EpiSense, just because the clamps in their current iteration are harder to deploy robotically. There's a lot of stuff in there, the angles. If they were to come up with something more like a stapler, like we use, like an Ethicon stapler that articulates and roticulates but can give bipolar, that'd be the ideal as far as energy delivery, because then you can bring it everywhere. But I'd probably do something with the EpiSense, do the right-sided lesions, roof floor, just like you showed, and then I would swing the robot 180 degrees coming from the left to complement and do a full box posterior wall, kind of belt and suspenders.
Man, that's my next iteration. If they could put the Synergy clamp on the end of a robotic arm effector, and you could have it wristed and move it around and get it around the veins, or even go straight across, that would be super cool. Because honestly, even the way I do it, I bring it in through the upper port so it'll come across, but bodies are different sizes.
Yeah.
It's so rigid and stiff, and it is puckering. It's puckering for me, and I'm doing them all. I do all the time, and so it's really puckering to try to teach somebody else how to do it. So there's a safety factor to that EpiSense device that's really, really nice. And I think that if you spend the time, you can get the right ablation done with any of the devices.
Yes.
You just have to take them out, the right amount of time,
Yeah.
and then do the appropriate amount of follow-up to know what you've done so that you can iterate to make it better.
Right. Because to your point, a bipolar clamp is the best energy device, and it'd be more efficient, very quick, as opposed to sitting there row after row. But and the dissection part's easy, like getting around the veins, but getting that clamp in its current iteration is really, I think, really hard. So that's why I stick with the EpiSense.
Stefano.
But hopefully technology will catch up.
Yeah, Stefano.
I wanted to add an important concept. Remember when we started this whole thing, we said we all need to speak the same lingo, okay? So when we say right side, we mean right pulmonary vein, not right atrium, okay?
Yeah,
correct.
There was an excellent study by Damiano's group that says that less than 20% of atrial fibrillation originates from the right side. And our colleague EP pathologists are excellent in managing that with percutaneously. So any atrial fibrillation that originates from the tricuspid, the isthmus, or the vena cava are manageable by catheter. We don't really have to be that aggressive with this type of approach.
Sure.
So when we say right-side approach is to do a better job on the pulmonary veins.
Yeah, to piggyback on that, that's my point, to make a perfect box. Because what I'm doing right now, I still rely on that second stage to complete the right side, finish the roof and floor. Gan, even if yours was completely standalone with no kind of touch-up work, you've done a nice, as perfect as you can get box. So mine's still only half. And unfortunately, we see a fair amount of traffic of these people who have they are contraindication anticoagulation, can't go to the cath lab for any endocardial ablation. And those are the ones where your technique really shines because you can give a full,
And I talk about this with Nivad all the time. We need so many more studies in the AFib world. I mean, and really, what's the value of a total box, meaning everything posterior to the box, including the pulmonary veins, to the full Cox Maze lesion set with the mitral isthmus. To Stefano's point, what's really the value to the right atrial lesions that we do? I still do a biatrial Cox Maze when I'm doing open on persistence, long-standing persistence, but a lot of times I'm thinking, how much value am I adding by the right atrial lesions when they can do a CTI line like this, and all of the other lines are arrhythmia-inducing, right? And I know that it can be kind of heretical for some people, but I think that CTS-NET trial back in the day, which really wasn't showing full mazes, it was showing a lot of the lesions were just PVIs and some of them were just boxes, and it showed 60-something% success. 30% of patients had success without any sort of ablation, but it showed 60-something% success, 66% success, and I think mostly of a box. I'm actually convinced if you have a true good posterior box and pulmonary veins, like actually transmural and effective, and you clip the left atrial appendage, that's probably going to be pretty close to 80% success of the Maze procedure. And you can get some incremental improvement with mitral lines or whatnot. But I think what we have an opportunity as surgeons is to provide that platform, that posterior wall, that box, that veins, so that anything else that happens is, that the EPs have to work on is anterior to that, whether it's right atrial or whether it's just anterior isthmus. And so, we'll see what happens in an ideal world. In my mind, I think, what's the ideal procedure that we could do surgically? And I think it would be one side, probably left side, where you can get a complete box and a clip and everything can be done in under 30 minutes. Like that, if you could do that, that's like,
Holy Grail.
The best. Yeah,
exactly. So I want to finish and wrap up. I think that the webinar was fantastic. It's almost an hour and 43 minutes. I've never done such a long webinar. And I feel that we can keep continually talking and chit-chatting. reality, I think that there are like series of messages that you can take home from all of this long conversation. First message is atrial fibrillation is something that surgeon needs to know, respect, understand, learn, and you should be an advocate for treatment of atrial fibrillation. When your patient comes in your office for that CABG or that AVR, you need to, or a mitral, you need to ask the right question. As Stefano said, consider to put an Holter monitor, start to think proactively to detect atrial fibrillation, ask about palpitation, and then treat. Treat via sternotomy, learn what is a maze, and learn how to do it well. It should be a standardized approach. We are talking about sternotomy. You need to do a maze in the patients. You need to clip the left atrial appendage, and you need to do this stuff right. There is no excuses for not treating a patient that comes for any type of sternotomy procedure. The next step is, I believe that there is a great opportunity, and I'm talking to all of these young cardiothoracic surgeons, couple of years out of training, struggling in their own institution to get some cases, taking the worst CABG of the worst and the worst endocarditis of the worst. Maybe you could start to think atrial fibrillation as a great job opportunity, as a very technical and also enlightening and very intelligent opportunity to grow into it. Start to speak with your intervention, with your EP, start to speak with the community, start to think about a minimal invasive approach for those patients that how did you say again? Not have failed catheter.
Non-responders.
Non-responder. Resistant to catheter. Non-responder. And then start to partner with them. Bring them inside the operating room. Let them mapping. Start to learn what a map is. You saw some of this picture of the left atrium, the red, the blue, the violet. I mean, if you are a mitral valve surgeon, you need to know how to read the transesophageal echocardiogram. If you are an heart surgeon dedicated to atrial fibrillation, you need to speak, as Stefano said, with your EP, showing you a map and know what you are looking at. And you need to start to think that this is extremely important and start to learn from them how to do it.
One follow-up, Gianluca,
go.
Is that if you have a robust atrial fibrillation practice, there's quite a halo effect to that. And about at least 10%, maybe more, of patients that are sent to me just for AFib need to have another concomitant procedure. Yeah. They need to have coronaries or valve work. So when you're a young surgeon trying to grow a practice, and I really wholeheartedly admire what you're saying right there, is to surgeons trying to find. It's hard to get a mitral valve if you're in your first couple years out, because your senior partners all want to steal those. Like, if you get into atrial fibrillation, you'll have more opportunity with more cases, because one, they're being sent to you for the AFib, but two, you can't really fix AFib unless you fix the underlying problems, and so you'll get a lot of those things sent to you as well.
Gianluca, I wanted to add a brief concept to what Gan said. It's actually a lot easier than anybody might think to develop an atrial fibrillation practice. Number one, the majority of patients you will operate, whether it's through sternotomy, robotically, or anything, will have a little bit of atrial fibrillation. I can guarantee you that. If you know that they have atrial fibrillation and you didn't address it at a minimum with excluding the left atrial appendage, it's an equivalent, and this is for dedicated to Gianluca, who is a coronary surgeon. It's like doing a CABG without putting a lima to the LAD. You are affecting their long-term survival, okay? The second thing is, what we discussed today, minimal invasive approach, are for lone atrial fibrillation. But if you're treating patients with mitral valve disease, coronary artery disease, or whatever other disease, please do something about it. Don't ignore it, because you will improve your patient outcome.
Yeah, I completely agree. And, we spend so much time saying second arterial conduit, the value of a radial, the value of a RITA. But if that patient comes with atrial fibrillation and you do a radial LITA and vein, rather than a LITA and 2 veins, but you don't treat the atrial fibrillation, the 10 years outcomes are most likely dependent by the fact that you didn't do anything for that atrial fibrillation, rather than if you have chosen a second arterial conduit or you put 2 veins on that patient. So atrial fibrillation kills more patients than the second arterial adjunct benefit of an obtuse marginal. And with this one, I will say we had so many people who congratulated us, who are watching us from all over the world. We have, at this time, more than 428 people in different times live. I think these one are amazing, amazing results, amazing connection. We will try to really put everybody on the spot and on the map, and I will reply to all of the questions in a separate moment. It's also Sunday morning for all of us. We all have family and kids, and so I want to thank everybody. It was a great discussion, and I hope that this one it gives a great opportunity for someone of you out there to take way more seriously atrial fibrillation. Thank you again. And with this one, we conclude the stream. I ask you to stay on time or stay here, you guys, so we can say goodbye.
All righty. Thank you for putting this together.